Friends, this is a hypermature Morgagnian cataract. The patient developed phacolytic glaucoma, which has been managed conservatively. Now the patient has been taken for surgery. The pupil is not dilating well, so after making all the incisions, staining the anterior capsule, a pupil expansion device is being used. This is BHEX pupil expander, invented by Dr. Suven Bhattacharjee of Kolkata, India. It has got flanges and notches. Alternate flanges are tucked under the iris and the other flanges remain above the iris. And now visco is injected, and see what happens as I try to do capsulorhexis. As I make a puncture in the anterior capsule, as I try to make a puncture, the whole lens moves, indicating zonular weakness, and a lot of milky fluid has come out. The milky fluid is aspirated, and then viscoelastic substance 2% SPMC is injected. And now as I try to do rhexis with Itrata forceps, see what happens. As I hold the capsular tag, see, the whole thing tends to come out. The whole bag tends to get disinserted. So only few zonules are there, and it is not possible to do rhexis in this case. Even if I try to do rhexis with some support of iris hooks, even then I thought it would not be possible to continue with phaco in this case. So I decided to remove the lens, and this is going to be an intracapsular cataract extraction. That is, the nucleus along with its capsule is going to be removed. This is how I disinsert the bag with the rhexis forceps from all around. Yes, and now I inject some more visco, and then take the vectis without irrigation. Just go behind the lens. The lens tumbles and the wound is adequate, and it comes out easily. And now my plan is to place a iris claw lens. The haptics are being placed at 2 o'clock, 8 o'clock positions. I'm not going to make 2 more side ports. The side ports are at 2 o'clock and 8 o'clock, and I'm going to fix the haptic in this meridian, 2 o'clock and 8 o'clock. So at 8 o'clock the haptic has been fixed to the iris, and now it is fixed to 2 o'clock. So the lens is nicely fixed, and now I inject triamcinolone acetate and find that there is some vitreous strands in the anterior chamber. coming from 5 o'clock to the anterior chamber. So I take vitrectomy cutter. This is 23 gauge cutter from Oakley. Machine being used is Oakley Cataract 3, which has got a pneumatic cutter and gives 1200 cuts per minute. Vacuum used is 175 millimeter of mercury, and flow rate is 30. So the anterior vitrectomy from anterior chamber is done. It's not possible to do a lot of vitrectomy. So what I do is I make an iridectomy just in front of the main incision, a big iridectomy. And now through this iridectomy I go behind the lens in the anterior vitreous and do a proper anterior vitrectomy. So this is a nice way of going behind the lens in case of iris claw lenses. Just we have to make a big iridotomy or iridectomy. We should not call it iridotomy because we are cutting the tissue. So surgical iridectomy, and through that iridectomy we do a nice anterior vitrectomy. This portion of the video is fast forwarded. The wound is being closed by a shoelace suture and 10-0 nylon. At this time the knot will not be tied, just placing the bites. And now inject visco and do a final lavage. But what I find that a lot of triamcinolone has gone in the anterior vitreous, and this may give rise to high intraocular pressure. IOP may rise because of this triamcinolone acetate. So I go again through the iridectomy opening behind the lens and do some more anterior vitrectomy to remove the triamcinolone acetate molecules. And now the knot is placed, and the knot gets buried in the wound. And now the side ports and all the wounds are hydrated. Moxifloxacin is injected in the anterior chamber, and then this is a releasable suture to oppose the conjunctiva to the limbus. Postoperatively, this patient did very well. Here are some post-op pictures. Cornea is clear, anterior chamber is quiet, intraocular lens is in place, intraocular pressure is 14 millimeter of mercury, and the patient is very happy with unaided 6/18 vision. Thank you very much for your attention. Hope this video will help you in developing your surgical skills and in overcoming some of the challenges in cataract surgeries.